Imagine walking into a packed emergency department where two patients arrive at the exact same time. One looks calm but is quietly dying. The other appears critical but can safely wait. Making the wrong decision in the first few minutes could cost a life, lead to legal consequences, and on the CEN exam, it could be the difference between passing and failing. That's why mastering emergency nursing starts with one skill above all others: knowing exactly who needs help first and why. Stay with me until the end of this lesson because we're going to break down these high-yield concepts in a simple, practical way that sticks. And don't forget to check the description, where you can download a free CEN study guide packed with some of the most important exam questions to help reinforce what you learned today. Welcome to the first section of your Certified Emergency Nurse Practice Prep course. In this lesson, you'll build the foundation every successful emergency nurse needs by learning how to rapidly assess patients, prioritize care using effective triage principles, and understand the legal and professional responsibilities that guide every decision in the emergency department. These are not just exam topics, they are real-world skills that help nurses recognize life-threatening conditions quickly, make confident clinical decisions under pressure, and provide safe, high-quality patient care. By the end of this lesson, you'll have a stronger understanding of the core concepts that appear repeatedly on the CEN exam and in everyday emergency practice. So get comfortable, stay focused, and let's begin building the knowledge and confidence that will help you succeed on exam day and beyond. The very first step in emergency nursing is triage, which simply means sorting patients based on how severely ill or injured they are. When a patient walks through the doors, you must immediately decide who can safely wait in the lobby and who needs to be seen by a doctor right this second. We do not evaluate them based on who arrived first, but rather on whose life is in the most immediate danger. This fast-paced decision-making requires a solid understanding of a standardized triage system, which ensures everyone gets the right level of care at the right time. In most modern emergency departments, we use a 5-level system called the Emergency Severity Index to classify patients. Level 1 represents a patient who is actively dying and needs immediate, life-saving interventions like chest compressions or a breathing tube. On the completely opposite end of the scale, Level 5 represents a patient with a minor problem, like a simple rash or a medication refill, who needs no special resources and can safely wait. Understanding these 5 levels is a massive part of your exam, as you will frequently be asked to assign the correct triage level to a hypothetical patient. The trickiest triage decisions usually involve distinguishing between Level 2 and Level 3 patients. A Level 2 patient is in a high-risk situation, perhaps experiencing chest pain or sudden confusion, and they should not wait to be evaluated. A Level 3 patient is stable but will require multiple resources, such as blood tests, X-rays, and intravenous fluids, to figure out what is wrong. If you ever hesitate between these two levels, ask yourself if the patient is in danger of deteriorating quickly, because if the answer is yes, they are immediately upgraded to a Level 2. Once you bring a patient back to a treatment room, you must immediately begin your primary survey, starting with their airway. The airway is the absolute highest priority because if the patient cannot breathe in oxygen, nothing else you do will matter. You must look, listen, and feel to determine if their throat and windpipe are completely clear of any blockages like blood, vomit, or severe swelling. If the airway is blocked or compromised, you must secure it immediately before moving on to any other part of your assessment. After ensuring the airway is open, you seamlessly move on to evaluating their breathing. Having an open airway does not guarantee that the patient is actually exchanging oxygen effectively in their lungs. You need to watch the rise and fall of their chest, count their breathing rate, and listen to their lung sounds with your stethoscope. If they are breathing too fast, too slow, or showing clear signs of struggling, you will need to provide supplemental oxygen or ventilation support right away. With the airway and breathing stabilized, your next focus in the primary survey is circulation. This means checking if the heart is pumping blood effectively to the rest of the body, which you can easily assess by feeling for a strong pulse and looking at the color of their skin. A fast, weak pulse accompanied by pale, sweaty skin is a major warning sign that the patient is experiencing a severe circulation problem. Your immediate actions here often include starting large intravenous lines and preparing to give fluids or life-saving blood products. The fourth step in the primary survey is assessing disability, which refers to a quick neurological check of the brain. We want to know the baseline brain function of the patient the moment they arrive, so we can easily tell if they get worse later on. The most common tool we use for this is the Glasgow Coma Scale, which grades how well they open their eyes, respond to your questions, and move their body. A sudden drop in their score means their brain is lacking oxygen or bleeding, and you must alert the medical team immediately. The final step of the primary survey is exposure, meaning you must carefully remove the clothing of a critically ill patient to examine their entire body. We simply cannot treat dangerous injuries that we cannot see, so it is vital to look for hidden bleeding, strange rashes, or unusual medical patches hidden under their clothes. However, while you are doing this, you must also work quickly to prevent the patient from getting too cold. Hypothermia can cause dangerous bleeding complications, so always remember to cover them back up with warm blankets as soon as your visual check is complete. Once all the immediate life-threatening issues found in the primary survey are handled, you move on to the secondary survey. This is a much more detailed, head-to-toe physical examination where you gather a complete and thorough picture of the health of the patient. Here, you take a full set of vital signs, gather a detailed medical history, and ask about their specific allergies and current medications. The secondary survey is where you play detective, looking for the underlying cause of the emergency rather than just treating the immediate and obvious symptoms. To make sure you do not forget anything important during the patient history, emergency nurses use a helpful acronym called SAMPLE. This stands for symptoms, allergies, medications, past medical history, last oral intake, and events leading up to the illness. By asking these specific questions, you create a comprehensive story of what happened before the patient arrived at your hospital doors. This information is gold for the doctor, as knowing exactly when the patient last ate or what new pill they took can completely change the medical treatment plan. Pain assessment is often considered the fifth vital sign, and it requires your careful attention during the triage and assessment process. You should always ask the patient to rate their pain on a numbered scale, but more importantly, you need to deeply understand the character of the pain. Ask them if it is sharp, dull, crushing, or burning, and find out exactly where it hurts and if the pain travels anywhere else. A patient describing a tearing pain in their back tells a completely different medical story than a patient describing a dull ache in their lower stomach. As an emergency nurse, you must also understand the strict federal laws that govern how we treat people, the most important being EMTALA. This specific law requires that every single person who comes to the emergency department must receive a medical screening exam to determine if they have a true emergency medical condition. You absolutely cannot refuse to examine someone simply because they do not have health insurance, and you cannot ask about their ability to pay until after they are medically stabilized. The certification exam loves to test your knowledge of EMTALA, so always remember that patient stabilization comes before any financial questions. Another major legal concept in emergency nursing is informed consent, which means a patient must understand a procedure and give you permission before you treat them. However, in a true life-threatening emergency where the patient is unconscious, confused, or unable to speak, the law implies that they would want you to save their life. This concept is called implied consent, and it legally allows you to perform emergency chest compressions, give vital medications, or start blood transfusions without waiting for written paperwork to be signed. Sometimes, the emergency department becomes an active crime scene, which brings us to the important basics of forensic nursing. When dealing with victims of violence, abuse, or serious accidents, you must carefully preserve any potential evidence, such as clothing, bullets, or even dirt on the skin. You must never cut through bullet holes or stab marks in a shirt, and you should always place clothing in breathable paper bags rather than plastic to prevent moisture from destroying evidence. Taking these careful steps ensures that you are treating the patient while also protecting the integrity of the legal investigation. One of the most difficult and emotional parts of your job will be identifying and reporting suspected cases of abuse or neglect. Whether it involves a vulnerable child, an elderly person, or a victim of domestic violence, you act as a legally mandated reporter. This means that if you see red flags of abuse, such as unexplained bruises or stories that do not match the physical injuries, you are legally required to report your suspicions to the proper authorities. Your primary goal is to ensure the patient is safe from further harm before they ever leave your care. You will inevitably deal with end-of-life situations in the emergency department, making advance directives incredibly important to understand. An advance directive is a legal document that explains exactly what kind of medical care a person wants if they become too sick to speak for themselves. You must always ask family members if the patient has a legal do not resuscitate order before beginning heroic measures like intubation or chest compressions. Respecting these final wishes is a profound part of nursing ethics, ensuring that we provide dignity and comfort when a cure is no longer possible. Following a tragic death in the emergency department, you may be involved in the delicate and complex process of organ donation. It is crucial to know that the medical team trying to save the life of the patient is kept completely separate from the team that handles organ recovery. Your role is simply to maintain the physical body of the deceased patient to preserve the health of their organs while a specialized coordinator approaches the grieving family for consent. You should never initiate the conversation about organ donation yourself, as this is always handled by trained procurement professionals. Finally, your excellent assessment skills are just as important when the patient is leaving the hospital as when they first arrive. Safe discharge planning begins the moment the patient walks through the door, as you constantly evaluate their living situation, family support, and ability to care for themselves at home. Giving clear, written instructions that the patient can easily read and understand is absolutely vital to prevent them from getting sicker and coming right back to the emergency room tomorrow. A safe and thoroughly educated discharge is the ultimate goal of a successful emergency department visit. I want to sincerely congratulate you for completing this first section of the course and taking a massive step toward your certification. You have just mastered the foundational principles of emergency triage, physical assessment, and professional legal responsibilities. Now, I highly encourage you to complete the attached practice test to see how well you absorbed the material. Practice questions improve your long-term retention and dramatically boost your overall exam readiness, and the test is included right here with this lesson. Embrace this active learning process, and when you are ready, let us naturally transition to the next section where we will tackle cardiovascular and respiratory emergencies together. Welcome to the second section of our course, where we explore the critical world of cardiovascular and respiratory emergencies. In this lesson, you will learn how to identify, assess, and treat the most dangerous conditions affecting the heart and lungs. These two systems are the engine of the human body, making this topic absolutely essential for your daily nursing practice and your upcoming certification exam. I am thrilled to help you master these complex concepts and turn them into easy, understandable knowledge. Get ready to focus, because mastering this section will truly make you a life-saving expert in the emergency room. To understand these emergencies, you first need to visualize how the heart and lungs work together as a perfect team. The heart relies on the lungs to fill the blood with fresh oxygen, and the lungs rely on the heart to pump that oxygenated blood to the rest of the body. When one of these systems begins to fail, the other is immediately forced to work harder to compensate for the problem. This is why a patient having a heart attack might suddenly struggle to breathe, and a patient with a lung problem might experience a dangerously fast heart rate. The most common and frightening cardiovascular emergency you will encounter is acute coronary syndrome, which is the medical term for a heart attack. This happens when the blood vessels that feed the heart muscle become blocked by a clot or a buildup of cholesterol. When the heart muscle is suddenly starved of oxygen, the patient typically feels a crushing, heavy pain in the center of their chest. Your immediate goal is to restore that blood flow as quickly as possible to prevent the heart muscle from permanently dying. When a patient arrives with chest pain, your absolute first step is to get a 12-lead electrocardiogram, or EKG, within 10 minutes of their arrival. The EKG tells you if the patient is having a massive, full blockage, known as a STEMI, or a partial blockage, known as a non-STEMI. A STEMI requires immediate emergency surgery in the cardiac catheterization lab to physically open the blocked artery with a balloon and a stent. Identifying these specific EKG changes quickly is a massive part of your certification exam, so always remember that time equals muscle. While waiting for the doctor to interpret the EKG, you must quickly begin the standard medical treatments for chest pain. You will often administer aspirin, which prevents blood clots from getting bigger, and nitroglycerin, which helps open up the blood vessels to improve blood flow. We also provide supplemental oxygen if the oxygen levels of the patient are low, and we may give specific pain medications to reduce the workload on the heart. These initial steps are crucial for stabilizing the patient and preventing the heart attack from causing further immediate damage. It is highly important to remember that not every patient having a heart attack will complain of classic, crushing chest pain. Women, the elderly, and patients with diabetes frequently experience atypical symptoms, which can make diagnosing them much more difficult. Instead of chest pain, they might only complain of extreme fatigue, sudden nausea, dizziness, or a vague discomfort in their jaw or shoulder. The exam will definitely test your ability to recognize these hidden heart attacks, so you must always keep your index of suspicion high with these specific patient groups. Another major cardiovascular topic is arrhythmias, which are abnormal heart rhythms caused by electrical problems inside the heart. One of the most common arrhythmias is atrial fibrillation, where the top chambers of the heart quiver instead of beating normally. This quivering allows blood to pool and form dangerous clots, which can travel to the brain and cause a massive stroke. Your emergency treatment will focus on slowing down the dangerously fast heart rate and giving blood thinners to prevent those deadly clots from forming. You must also be prepared to treat lethal arrhythmias, specifically ventricular fibrillation and pulseless ventricular tachycardia. In these chaotic rhythms, the heart is basically twitching and is completely failing to pump any blood to the body, meaning the patient has no pulse and is clinically dead. The only effective treatment for these specific lethal rhythms is immediate defibrillation, which is delivering a strong electrical shock to reset the heart. The exam will expect you to know that early high-quality CPR and early defibrillation are the absolute keys to surviving a sudden cardiac arrest. Moving away from the heart itself, you must be able to recognize an aortic dissection, which is a terrifying emergency involving the largest blood vessel in the body. This occurs when the inner layer of the aorta suddenly tears, allowing blood to forcefully rip the layers of the blood vessel apart. Patients typically describe this as a sudden, tearing, or ripping pain that radiates straight through to their upper back. A classic warning sign you might discover during your physical assessment is a significant difference in blood pressure between the left and right arms of the patient. A failing heart can quickly lead to a respiratory emergency, which is exactly what happens in congestive heart failure and pulmonary edema. When the heart becomes too weak to pump blood forward, that extra fluid backs up directly into the lungs, effectively drowning the patient from the inside. These patients will be gasping for air, their oxygen levels will drop dangerously low, and they may cough up a pink, frothy liquid. Your rapid treatment involves giving diuretic medications to force the kidneys to pee out the extra fluid, alongside specialized oxygen masks to push the fluid out of the lung spaces. Transitioning fully into the respiratory system, your first priority will always be securing a compromised airway. When a patient is entirely unable to breathe for themselves, you will assist the doctor with a process called rapid sequence intubation. This involves giving a powerful sedative to put the patient to sleep, followed immediately by a paralytic medication to relax their muscles, allowing a breathing tube to be placed directly into their windpipe. You must closely monitor the oxygen levels and vital signs of the patient throughout this high-risk procedure, as their life is completely in your hands. One of the most frequent breathing emergencies you will treat is an asthma exacerbation, which is a severe inflammatory attack inside the lungs. During an asthma attack, the small airway tubes suddenly swell up and squeeze tightly shut, making it incredibly difficult for the patient to push air out of their lungs. You will typically hear a high-pitched whistling sound called wheezing when you listen to their chest with your stethoscope. We treat this aggressively with inhaled medications like albuterol to open the airways, and systemic steroids to calm down the severe internal inflammation. You must be highly vigilant for a condition called status asthmaticus, which is a life-threatening asthma attack that absolutely refuses to respond to normal medical treatments. These patients are working so hard to breathe that their breathing muscles will eventually become exhausted and completely fail. A massive warning sign on your exam is the silent chest, which happens when the airways are so tightly closed that you can no longer hear any wheezing at all. A silent chest means no air is moving, and the patient requires immediate emergency ventilation to survive. Chronic obstructive pulmonary disease, or COPD, is another major respiratory illness that frequently brings patients into the emergency department. These patients suffer from long-term lung damage, usually from years of smoking, meaning their baseline breathing is always a struggle. When they experience a sudden worsening of their symptoms, they require careful oxygen therapy, but you must be cautious not to give them too much oxygen too quickly. Delivering excessive oxygen to a severe COPD patient can sometimes dangerously reduce their natural drive to breathe, which is a common scenario you will see on the certification exam. A pulmonary embolism is a silent killer that occurs when a blood clot travels through the body and becomes lodged directly inside the blood vessels of the lungs. This blocks blood from picking up oxygen, causing the patient to experience sudden, unexplained shortness of breath and a sharp pain in their chest when they take a deep breath. These clots almost always originate from a deep vein thrombosis, which is a clot located in the deep veins of the legs. Recognizing the risk factors, such as recent long travel, recent surgery, or prolonged bed rest, is essential for identifying this deadly condition. You also need to understand pneumothorax, which is the medical term for a collapsed lung caused by trapped air inside the chest cavity. The most dangerous form is a tension pneumothorax, where pressure builds up so high that it actually crushes the heart and the good lung. A classic exam sign of this extreme pressure is tracheal deviation, where the windpipe of the patient is visibly pushed completely to one side of their neck. The immediate emergency treatment for a tension pneumothorax is a needle decompression, where the doctor inserts a large needle into the chest wall to quickly release the trapped air. Acute respiratory distress syndrome, or ARDS, is a massive inflammatory response in the lungs that usually follows a severe infection or a major traumatic injury. The tiny air sacs in the lungs become filled with heavy inflammatory fluid, making it completely impossible for oxygen to enter the bloodstream. These patients are incredibly sick, deeply hypoxic, and almost always require advanced mechanical ventilation in the intensive care unit. On your exam, ARDS is often described as a chest X-ray that looks completely white, rather than the normal clear and dark appearance of healthy lungs. To fully evaluate complex respiratory patients, you must learn how to interpret arterial blood gas results, which are blood tests taken directly from an artery. This test tells you the exact pH balance of the blood, the amount of carbon dioxide they are retaining, and the precise level of oxygen in their system. If a patient is not breathing effectively, carbon dioxide will quickly build up in their blood, causing their body to become dangerously acidic. Mastering the basics of blood gas interpretation will give you a major advantage when facing difficult respiratory questions on your test. When facing scenario-based questions on the exam, remember that cardiovascular and respiratory symptoms frequently overlap and present multiple medical requirements. For example, a patient might present with both extreme shortness of breath and a dangerously irregular heart rate, forcing you to use your critical thinking skills to find the root cause. You must always rely on your primary survey and the ABCs, meaning airway, breathing, and circulation, to prioritize which life threat to fix first. Solving these multi-requirement scenarios correctly proves that you can handle the true complexity of emergency nursing. I want to deeply congratulate you for completing this second section of the course and mastering the complexities of cardiovascular and respiratory emergencies. You are making incredible progress, and I highly encourage you to complete the attached practice test right now to lock in this critical information. Practicing with these exam-style questions is the absolute best way to improve your memory retention and guarantee your overall exam readiness, and the test is conveniently included right here with this lesson. Keep up this fantastic momentum and active learning, and when you are ready, we will transition seamlessly into the next section covering neurological, shock, and trauma emergencies. Welcome to the third section of our course, where we tackle the intense and fast-paced world of neurological, shock, and trauma emergencies. In this lesson, you will learn how to manage traumatic injuries, stabilize different states of shock, and rapidly respond to severe brain events like strokes and seizures. This knowledge is incredibly important because these critical conditions require split-second decision-making to prevent permanent brain damage or loss of life. I am so excited to break down these advanced concepts into simple, easy-to-understand pieces. Get ready to elevate your critical thinking skills as we explore these high-stakes emergencies together. To begin, we must thoroughly understand the concept of shock, which is a life-threatening medical condition where the body is not getting enough blood flow. When blood flow drops, the cells in the body are starved of the vital oxygen they need to survive and function correctly. If shock is not quickly recognized and reversed, those starved cells will begin to die, leading to massive organ failure and eventually death. Your ability to catch the early, subtle signs of shock is a critical skill that the certification exam will test heavily. The most common type of shock you will see in trauma patients is hypovolemic shock, which literally means low blood volume. This happens when a patient loses massive amounts of blood from a severe injury, or even large amounts of fluid from severe vomiting or burns. When the tank is empty, the heart pumps faster to try and circulate whatever little fluid is left, resulting in a very fast heart rate and a very low blood pressure. Your immediate goal is to stop any active bleeding and rapidly refill the tank with warm intravenous fluids and emergency blood transfusions. Another major category is cardiogenic shock, which happens when the heart muscle is too damaged to pump blood effectively, usually following a massive heart attack. In this specific scenario, the tank is totally full, but the pump itself is broken and failing. Giving massive amounts of intravenous fluids to these patients is actually extremely dangerous, because their weak heart cannot handle the extra volume and the fluid will back up into their lungs. Instead, you must carefully administer specialized medications to help the heart muscle squeeze harder and pump more efficiently. Distributive shock is a very tricky category where there is plenty of blood and a working pump, but the blood vessels themselves have suddenly expanded too much. Imagine water flowing through a normal garden hose, and then suddenly the hose becomes the size of a massive fire hose, causing the water pressure to drop to zero. This dangerous expansion of blood vessels can be caused by a severe allergic reaction, a massive infection, or a severe spinal cord injury. To treat this, we give specific medications called vasopressors to forcefully squeeze those blood vessels back to their normal, tighter size. A very common and terrifying form of distributive shock is anaphylaxis, which is a severe and rapid allergic reaction to something like a bee sting, medication, or food. The throat of the patient can swell shut in a matter of minutes, while their blood pressure simultaneously drops to dangerous levels. The absolute most important treatment for anaphylaxis is the immediate injection of epinephrine into the thigh muscle. Epinephrine works like magic to instantly open up their breathing passages and tightly squeeze their blood vessels to restore normal blood pressure. Neurogenic shock is another unique type of distributive shock that typically occurs directly after a severe injury to the upper spinal cord. The injury cuts off the communication signals from the brain that normally tell the blood vessels to stay tight and tell the heart to beat fast. As a result, the blood vessels wildly relax and the heart rate becomes dangerously slow, which is a highly unique combination. On your exam, remember that neurogenic shock is the only type of shock where the patient will have low blood pressure combined with a slow heart rate and warm, dry skin. Shifting our focus to trauma, the overall management of a severely injured patient relies entirely on a standardized, systematic approach called the primary survey. As we discussed earlier, you must rapidly move through the airway, breathing, circulation, disability, and exposure assessment without getting distracted by obvious, gruesome injuries. It is very easy to focus on a bleeding broken leg, but if the patient has a blocked airway, that broken leg does not matter because they will not survive. Always trust your primary survey to keep your priorities straight during chaotic trauma resuscitations. Understanding the mechanism of injury is a crucial detective skill when assessing a new trauma patient in the emergency department. If you know exactly how the patient was injured, like the speed of a car crash or the height of a fall, you can actually predict internal injuries before you even see them. For example, a patient whose chest violently hit a steering wheel is at massive risk for a bruised heart or torn major blood vessels, even if their skin looks perfectly fine. You must use the story of the accident to guide your focused physical assessment and catch hidden, life-threatening damage. Head trauma is a major focus on the certification exam, particularly when dealing with different types of bleeding inside the skull. An epidural hematoma is an extremely dangerous arterial bleed that happens when the side of the head is struck hard, like being hit with a baseball bat. These patients classically lose consciousness, then wake up and seem completely fine for a short period called the lucid interval, before suddenly deteriorating and slipping into a coma. This rapidly expanding blood clot pushes directly on the brain and requires immediate emergency brain surgery to relieve the extreme pressure. In contrast, a subdural hematoma is a slower venous bleed that is very common in elderly patients or individuals who take daily blood thinners. Because as we age our brains naturally shrink slightly, there is more room for the tiny veins connecting the brain to the skull to stretch and slowly tear during a minor fall. The symptoms of a subdural hematoma can take days or even weeks to appear, making it very easy to confuse with normal confusion or dementia. You must always perform a very careful neurological assessment on an elderly patient who reports a recent fall, no matter how minor it seemed. As blood pools inside the rigid skull from any head injury, the pressure inside the brain, known as intracranial pressure, begins to rise to dangerous levels. When the pressure gets too high, the brain is physically crushed and pushed downward toward the spinal cord in a deadly process called herniation. You must be able to recognize Cushing's triad, which is a classic late warning sign of massive brain pressure, This deadly trio of symptoms includes a dangerously high blood pressure, a very slow heart rate, and an irregular, gasping breathing pattern. Moving away from physical trauma, we must discuss acute strokes, which are massive medical emergencies affecting the brain. An ischemic stroke happens when a blood clot travels into the brain and blocks a blood vessel, starving a specific area of the brain of oxygen. A hemorrhagic stroke happens when a weak blood vessel actually bursts open and bleeds directly into the delicate brain tissue. Both types of stroke can cause sudden weakness on one side of the body, slurred speech, and facial drooping, making them impossible to tell apart without a medical scan. Because you cannot visibly see if the stroke is caused by a clot or a bleed, the absolute priority upon arrival is to rush the patient to a computed tomography, or CORT, scanner. The CORT scan is a highly detailed X-ray of the head that will instantly show if there is active bleeding inside the brain. This is crucial because the treatments for these two types of strokes are completely opposite, and giving the wrong medication can be instantly fatal. The exam will definitely test your knowledge of prioritizing this immediate brain scan before giving any specialized stroke medications. If the CORT scan shows no bleeding, the patient is likely having an ischemic stroke caused by a clot, and they might qualify for powerful clot-busting medications called thrombolytics. However, these powerful drugs can only be given within a very strict, short time window after the symptoms first started, typically around 3 to 4 hours. This is exactly why establishing the true time of onset, or the last known well time of the patient, is your most vital assessment question. If the patient woke up with the stroke symptoms, the true start time is unknown, and they unfortunately cannot safely receive the clot-busting drugs. Seizures are another intense neurological emergency where the electrical system of the brain suddenly fires out of control, causing the patient to lose consciousness and violently shake. Most seizures naturally stop on their own after a few minutes, during which your only job is to protect the airway and keep the patient safe from hitting nearby objects. However, if a seizure lasts longer than 5 minutes, or if they have back-to-back seizures without waking up, it becomes a deadly emergency called status epilepticus. In this scenario, you must quickly administer powerful sedative medications like lorazepam or diazepam into their veins to forcibly stop the electrical storm in their brain. Spinal cord injuries require extreme caution and precision from the moment the patient arrives in the emergency department. If there is any suspicion of a neck or back injury from a trauma, you must keep the spine perfectly aligned and restrict all spinal motion using a rigid collar and careful positioning techniques. If this patient suddenly stops breathing, you absolutely cannot tilt their head back to open their airway like you normally would. Instead, you must use a specialized technique called the jaw thrust maneuver, which safely lifts the jawbone forward to open the airway without moving their injured neck. When facing challenging exam scenarios involving severe multi-trauma patients, you must consistently apply strong prioritization logic to find the correct answer. The exam frequently presents complex situations with 2 or more simultaneous life threats, testing if you truly understand what will kill the patient first. Always revert back to your airway, breathing, and circulation principles, and never let a distracting, bloody wound make you forget to secure an unstable airway first. Managing these multi-requirement logic puzzles correctly demonstrates your advanced ability to think clearly under immense clinical pressure. We have covered an incredible amount of heavy, complex information in this section, from managing massive blood loss to identifying the subtle signs of brain bleeding. Understanding how these neurological and trauma systems interact will drastically improve your clinical reasoning when working on the emergency room floor. Remember to look beyond the obvious symptoms, predict hidden injuries based on the story of the event, and always prioritize immediate life threats. Keeping these fundamental concepts at the front of your mind will make you an incredibly safe and highly effective emergency nurse. I want to sincerely congratulate you for completing this intense 3rd section of the course and conquering neurological, shock, and trauma emergencies. You are doing a phenomenal job building your advanced clinical knowledge, and I am very proud of your continued dedication. Please take a few moments right now to complete the attached practice test to reinforce everything you have just learned. Practicing these complex scenario questions greatly improves your long-term retention and guarantees your readiness for exam day, and the test is included right here with this lesson. Keep utilizing active learning, and when you are ready, we will transition naturally into the next section covering medical, communicable, and toxicological emergencies. Welcome to the 4th section of our course, focusing on the incredibly diverse categories of medical, communicable, and toxicological emergencies. In this lesson, you will learn how to identify severe systemic infections, manage dangerous hormonal imbalances, and rapidly treat life-threatening drug overdoses. This topic is profoundly important because these sneaky, hidden conditions require you to be a brilliant medical detective to save your patient and pass your certification exam. I am so excited to guide you through these complex mysteries and help you build a massive foundation of critical thinking skills. Grab a comfortable seat, clear your mind, and let us dive into mastering these fascinating emergency room presentations. We must begin with one of the most dangerous and deadly conditions you will ever face, which is severe sepsis. Sepsis is not just a simple infection, but rather a massive, chaotic overreaction by the immune system to an infection somewhere in the body. Instead of just fighting the bacteria, the immune system begins attacking healthy organs, causing widespread inflammation and leaky blood vessels. If you do not recognize this runaway train immediately, the blood pressure of the patient will crash, leading to a deadly state known as septic shock. Catching sepsis early requires you to be highly vigilant during your initial patient assessment and vital sign checks. You must actively look for a combination of suspicious signs, such as a very high or unusually low temperature, a dangerously fast heart rate, and a rapid breathing rate. Another massive early warning sign is a sudden change in mental status, like an elderly patient who suddenly becomes confused or profoundly sleepy. The certification exam loves to test your ability to spot these subtle early clues before the patient completely crashes into full organ failure. When you suspect sepsis, you must immediately initiate a time-sensitive protocol known as the sepsis bundle. Within the very first hour of their arrival, you must draw blood cultures to identify the specific bacteria, and then administer powerful, broad-spectrum intravenous antibiotics. Simultaneously, you will aggressively pump large amounts of intravenous fluids to fill up their leaky blood vessels and keep their blood pressure stabilized. Remembering this specific order of operations, especially drawing the blood cultures before giving the antibiotics, is absolutely crucial for your exam success. Shifting to endocrine emergencies, you must deeply understand diabetic ketoacidosis, commonly known as DKA. This happens primarily in patients with type 1 diabetes when their body has absolutely no insulin to move sugar from the blood into the cells. Because the starving cells cannot use sugar for energy, the body panics and starts burning fat instead, which creates dangerous, acidic byproducts called ketones. These patients will have very high blood sugar, a fruity smell to their breath, and deep, rapid breathing as their body desperately tries to blow off the excess acid. The immediate emergency treatment for diabetic ketoacidosis requires very careful and precise nursing interventions. You will first give them plenty of intravenous fluids to reverse their severe dehydration, and then start a continuous drip of regular insulin to slowly bring down their blood sugar. However, you must constantly monitor their potassium levels, because insulin forcefully pushes potassium out of the blood and back into the cells. If you give insulin without paying attention, their potassium levels will drop dangerously low, potentially causing a lethal heart arrhythmia. You also need to recognize hyperosmolar hypoglycemic state, which is a similar but distinct emergency usually seen in older patients with type 2 diabetes. Unlike DKA, these patients still produce just enough of their own insulin to prevent their body from breaking down fat, so they do not develop those dangerous acidic ketones. However, their blood sugar levels rise incredibly high, pulling massive amounts of water out of their body and causing profound, life-threatening dehydration. Your primary focus here is massive and aggressive fluid replacement to rehydrate their severely dried-out brain and organs. Thyroid emergencies are another major endocrine topic that requires rapid recognition and treatment in the emergency department. Thyroid storm is a terrifying condition where the thyroid gland becomes hyperactive, flooding the body with hormones and causing a dangerously fast heart rate, extreme fever, and severe agitation. On the exact opposite end of the spectrum is myxedema coma, where the thyroid completely stops working, causing a dangerously slow heart rate, extreme coldness, and profound lethargy. Both of these extreme conditions are deadly and require specialized medications to either block the extra hormones or quickly replace the missing ones. Moving on to communicable diseases, your absolute first priority as an emergency nurse is protecting yourself, your coworkers, and your other patients. When a patient arrives with a contagious illness, You must immediately isolate him to stop the disease from spreading through the hospital ventilation system or waiting room. Understanding the specific isolation precautions for different diseases is not just important for passing your exam, it is a legal and ethical requirement of your daily job. You must know exactly what protective gear to wear before you ever step foot inside that patient room. Airborne precautions are used for diseases that float freely through the air on tiny particles, such as tuberculosis, measles, and chickenpox. These patients must be placed in a specialized negative pressure room, which acts like a vacuum to suck the contaminated air outside the hospital. Before entering this room, you are strictly required to wear a specialized, tight-fitting N95 respirator mask to filter out those tiny, dangerous particles. The exam will frequently present a patient with a chronic cough, night sweats, and weight loss, expecting you to immediately choose airborne precautions for suspected tuberculosis. Droplet and contact precautions are used for diseases that spread through heavier fluids or direct physical touch. For droplet diseases like influenza or bacterial meningitis, the germs travel in heavy sneezes or coughs, so you must wear a standard surgical mask and eye protection. For contact diseases like MRSA or certain severe diarrheal infections, the germs live on the skin and surfaces, requiring you to wear a gown and gloves. A highly tested fact is that for patients with Clostridium difficile, or C. diff, standard alcohol hand sanitizer does not kill the spores, meaning you must wash your hands vigorously with actual soap and water. Transitioning into toxicology, we enter the fascinating world of treating dangerous poisonings and deliberate drug overdoses. A massive key to toxicology is recognizing specific toxidromes, which are distinct clusters of symptoms that point directly to a certain type of drug or chemical. Because patients who have overdosed are often unconscious or lying about what they took, you must rely entirely on your physical assessment to solve the mystery. Identifying these classic toxidrome patterns will rapidly guide you toward the correct life-saving antidote. The opiate toxidrome is the most common overdose you will see, caused by drugs like heroin, fentanyl, or prescription pain pills. Opiates heavily depress the central nervous system, leading to a classic triad of recognizable symptoms in your patient. You will find them deeply unconscious, breathing extremely slowly or completely turning blue, and having tiny, pinpoint pupils when you shine a light in their eyes. Recognizing this specific triad of symptoms instantly tells you that the patient needs immediate airway support and the opiate antidote. The miraculous antidote for an opiate overdose is naloxone, commonly known as Narcan, which rapidly knocks the opiate drugs off the brain receptors and wakes the patient up. However, the certification exam will absolutely test your knowledge of the dangerous half-life of this medication. Narcan wears off much faster than most long-acting opiates, meaning the patient can suddenly slip back into a deadly coma an hour after you saved them. You must continuously monitor an opiate overdose patient and be fully prepared to administer multiple, repeated doses of Narcan. The stimulant toxidrome is the exact opposite of an opiate overdose, usually caused by drugs like cocaine or methamphetamines. These patients are completely wired, presenting with a dangerously fast heart rate, extremely high blood pressure, massively dilated pupils, and severe paranoia or aggression. Your primary goal is to prevent them from having a heart attack or a massive stroke from the extreme blood pressure. We treat this highly dangerous state using supportive care and calming medications like benzodiazepines to safely slow down their racing brain and heart. Acetaminophen, known commonly as Tylenol, is one of the most deadly but deceptive overdoses you will encounter in emergency nursing. When taken in massive amounts, it slowly and silently destroys the liver over a period of several days. The tricky part is that the initial symptoms are incredibly mild, often just slight nausea or a vague stomach ache, which can easily fool an inexperienced nurse. The exam expects you to know that the specific life-saving antidote for a Tylenol overdose is a medication called N-acetylcysteine, which must be given early to protect the liver from permanent failure. A salicylate overdose, which comes from taking too much aspirin, creates a very complex metabolic emergency inside the body. These patients will often complain of a loud ringing in their ears and will be breathing very rapidly as their body tries to balance dangerous changes in their blood chemistry. To treat an aspirin overdose, you will often administer intravenous fluids mixed with sodium bicarbonate. This specific treatment makes their urine more alkaline, which helps their kidneys quickly flush the toxic aspirin directly out of their system. Finally, You must understand the basic principles of physical decontamination when a patient has been exposed to dangerous chemicals. If a patient is covered in a toxic liquid or powder, you must carefully remove all of their clothing and wash their skin with massive amounts of water before bringing them into the main emergency department. For patients who have swallowed certain toxic pills, we may sometimes give them a thick liquid called activated charcoal to drink. The charcoal acts like a magnet inside their stomach, tightly binding to the poison so it naturally passes through their digestive system without entering their bloodstream. When preparing for scenario questions on the exam, remember that toxicology and communicable diseases often require a multi-step thought process. You will read a complicated paragraph describing a sick patient, and you must first diagnose the underlying problem using their subtle symptoms. Once you diagnose the problem in your head, you must immediately apply the correct safety protocol or select the specific chemical antidote to fix it. Mastering this chain of logic proves that you are ready to handle the chaotic and unpredictable nature of the emergency department floor. I want to highly congratulate you for completing this fourth section of the course and expanding your expertise into medical, communicable, and toxicological emergencies. You are building a brilliant foundation of knowledge, and I strongly encourage you to complete the attached practice test while this information is fresh in your mind. Using these practice questions deeply improves your memory retention and ensures your absolute readiness for the real certification exam, and the test is included right here with this lesson. Please continue this wonderful active learning habit, and when you are completely ready, we will naturally transition to the next section covering gastrointestinal, genitourinary, and obstetric emergencies. Welcome to the fifth section of your course, where we will explore gastrointestinal, genitourinary, and obstetric emergencies. In this lesson, you will learn how to evaluate complex abdominal pain, handle serious kidney problems, and safely manage life-threatening pregnancy complications. This topic is incredibly important because abdominal complaints are among the most common reasons patients visit the emergency room, and they require sharp detective skills to diagnose correctly. I am thrilled to help you unpack these challenging medical mysteries and turn them into easy, understandable concepts. Let us dive right in and boost your diagnostic confidence. Assessing a patient with abdominal pain requires a very specific, step-by-step approach to avoid causing them unnecessary harm. Unlike the rest of the body, you must always look at the abdomen first, then listen to the bowel sounds with your stethoscope, and only touch or press on the stomach at the very end. If you press on a painful stomach too early, you could cause the patient severe pain, and they will tense up their muscles, making the rest of your physical examination completely impossible. One of the most classic surgical emergencies you will encounter is acute appendicitis, which is an infection of a small pouch attached to the large intestine. The pain typically starts right around the belly button and slowly moves down to the lower right side of the stomach over a few hours. These patients often experience a specific symptom called rebound tenderness, meaning it actually hurts them much more when you quickly let go of their stomach than when you press down. If the infected appendix bursts, dangerous bacteria will flood the entire abdominal cavity, creating a deadly infection. Moving to the upper right side of the stomach, we find the gallbladder, which can become blocked by painful gallstones in a condition called cholecystitis. Patients with gallbladder issues usually complain of sharp pain that starts shortly after they eat a very greasy or high-fat meal. A classic exam finding is Murphy's sign, where you press gently under their right rib cage, and they suddenly stop breathing in because the pain is so sharp. Recognizing this specific pain location and trigger will easily guide you to the correct answer on your test. Pancreatitis is another incredibly painful emergency, caused by severe inflammation of the pancreas, usually triggered by heavy alcohol use or migrating gallstones. This pain is very distinct because it is located in the upper middle stomach and famously radiates straight through to the back of the patient. The pancreas helps digest food, so eating makes the pain much worse. Your primary treatment involves keeping their stomach completely empty, pumping them full of intravenous fluids, and providing very strong pain medications. Gastrointestinal bleeding is a terrifying emergency that is categorized by where the bleeding starts inside the digestive tract. An upper GI bleed usually happens in the stomach or esophagus, causing the patient to vomit bright red blood or dark material that looks exactly like coffee grounds. A lower GI bleed happens in the intestines, causing bright red blood to appear in their stool. Because they're losing whole blood, these patients are at a massive risk for hypovolemic shock, requiring you to act fast with large intravenous lines and emergency blood transfusions. The most dangerous form of an upper GI bleed comes from esophageal varices, which are swollen, fragile veins in the throat caused by severe liver disease. When one of these veins suddenly bursts, the patient will experience massive, uncontrollable vomiting of bright red blood. This is a true airway emergency, because the patient can easily choke and drown in their own blood. You must immediately assist the doctor in protecting the airway while simultaneously pushing massive amounts of emergency blood to save their life. Sometimes the intestines simply stop moving or become physically twisted, creating a painful traffic jam called a bowel obstruction. These patients will have a very bloated, tight stomach, and they will be vomiting continuously because nothing can move forward through their digestive system. They will also be completely unable to pass gas or have a bowel movement. The standard emergency treatment is placing a long plastic tube through their nose and directly into their stomach to pump out the trapped fluid and relieve the intense pressure. Shifting our focus to the genitourinary system, you will frequently treat patients suffering from agonizing kidney stones. These tiny, hard rocks get stuck in the tubes draining the kidneys, causing extreme pain in the side of the back that shoots straight down into the groin. Unlike a patient with appendicitis who wants to lay perfectly still, a patient with a kidney stone will constantly pace around the room trying to find a comfortable position. Your goal is to provide fast pain relief, push fluids to help them flush the stone out, and give them a small strainer to catch the stone when they pee. You must also be highly vigilant for severe kidney infections, medically known as pyelonephritis, which usually start as a simple bladder infection. While a simple urinary tract infection causes burning when urinating, a kidney infection travels further up into the body, causing high fevers, shaking chills, and deep pain in the middle of the back. These infections are incredibly dangerous, especially in elderly patients, because the bacteria can easily cross into the bloodstream and trigger deadly septic shock. Patients with severe, end-stage kidney disease rely on a dialysis machine to filter their blood because their own kidneys no longer work. If a patient misses a scheduled dialysis appointment, dangerous toxins and electrolytes will quickly build up in their bloodstream. The absolute most dangerous electrolyte is potassium, and when potassium levels get too high, it aggressively attacks the electrical system of the heart. On your certification exam, always remember that high potassium causes tall, pointy T waves on an EKG, warning you that a lethal heart arrhythmia is about to happen. Torsion is a terrifying surgical emergency that can happen to both the testicles in men and the ovaries in women. This occurs when the organ literally twists around inside the body, completely cutting off its own blood supply and causing sudden, agonizing, one-sided pain. In torsion, time equals tissue, meaning you have a very short window of only a few hours to get the patient into an operating room to untwist the organ. If you wait too long, the starved tissue will permanently die and the organ will have to be completely removed. As we transition into obstetric and gynecologic emergencies, ectopic pregnancy is an absolutely critical concept you must memorize. This happens when a fertilized egg gets stuck and starts growing inside the tiny fallopian tube instead of safely inside the main uterus. As the baby grows, the tube will stretch and eventually explode, causing massive, life-threatening internal bleeding into the stomach. Because of this deadly risk, you must always perform a rapid pregnancy test on every single woman of childbearing age who complains of lower abdominal pain. If a patient is safely pregnant, but in their third trimester, they are at risk for preeclampsia, which is dangerously high blood pressure caused by the pregnancy itself. These mothers will have protein in their urine, severe swelling in their face and hands, and complain of a pounding headache or blurry vision. If this high blood pressure is not controlled, it will escalate into eclampsia, meaning the mother will suffer a massive, life-threatening seizure. We treat this highly dangerous condition by giving a continuous drip of magnesium sulfate to relax their brain and prevent the seizures from happening. You must also understand two major bleeding emergencies related to the placenta, which is the lifeline between the mother and the baby. Placenta previa happens when the placenta grows directly over the exit of the cervix, causing painless, bright red bleeding when the cervix begins to stretch. Placental abruption is vastly different and happens when the placenta violently tears away from the wall of the uterus before the baby is born. Abruption is usually caused by severe trauma or cocaine use, causing agonizing pain, dark red bleeding, and instantly cutting off the oxygen supply of the baby. Occasionally, an expectant mother will arrive at the emergency department fully dilated, meaning you must perform a rapid emergency delivery right there in the room. Your primary goal is to stay calm, gently support the head of the baby to prevent the mother from tearing, and absolutely never pull forcefully on the baby. The moment the baby is born, you must immediately dry them off with warm towels. Drying the baby keeps them warm while also physically stimulating them to take their very first deep breath of air. Immediately after the baby is delivered, the mother is at a massive risk for a postpartum hemorrhage, which means she is bleeding too heavily. The most common cause is a tired uterus that forgets to squeeze itself tight to stop the bleeding blood vessels. Your very first nursing intervention is an emergency fundal massage, where you forcefully push and rub the lower stomach to physically stimulate the uterus to cramp down and stop the bleeding. If the bleeding continues, you must be ready to administer special medications and prepare for emergency blood transfusions. Pelvic inflammatory disease is a severe, widespread infection of the female reproductive organs, usually caused by untreated sexually transmitted infections. These patients will have a high fever, foul-smelling discharge, and extreme pain when their cervix is examined by the doctor. This infection creates thick scar tissue inside the delicate fallopian tubes, which is exactly what traps fertilized eggs in the future. This is why pelvic inflammatory disease is the absolute highest risk factor for a patient developing a deadly ectopic pregnancy later in life. When tackling complex scenario questions on your exam, always remember to mentally map out the abdomen to narrow down your choices. If the question describes right lower quadrant pain, immediately think of the appendix. If the pain is in the right upper quadrant after a greasy meal, immediately think of the gallbladder. If it is a young woman with sudden, sharp, one-sided lower pain, always rule out an ectopic pregnancy first. Using this simple process of elimination based on geography will save you massive amounts of time and guide you to the correct answer. I want to highly congratulate you for completing Section 5 and mastering the complexities of gastrointestinal, genitourinary, and obstetric emergencies. You have added a massive amount of crucial diagnostic knowledge to your toolkit today. Please take a few moments right now to complete the attached practice test to reinforce everything you have learned. Practicing with these scenarios dramatically improves your long-term retention and guarantees your readiness for exam day, and the test is included right here with this lesson. Keep up this brilliant active learning, and when you are completely ready, we will transition to our final section covering orthopedic, environmental, and psychosocial emergencies. Welcome to the sixth and final section of your Certified Emergency Nurse Preparation course, covering orthopedic, environmental, and psychosocial emergencies. In this lesson, you will learn how to stabilize dangerous bone fractures, treat severe temperature exposures, and safely manage mental health crises. This topic is profoundly important because these diverse emergencies require you to adapt quickly to unpredictable situations on the emergency room floor. I am incredibly excited to help you cross the finish line and perfect your knowledge for the certification exam. Take a deep breath, focus your mind, and let us dive into mastering these final life-saving concepts. When evaluating orthopedic injuries, such as broken bones or dislocated joints, your priority is always assessing the neurovascular status of the injured limb. Before you ever apply a splint or bandage, you must check if the patient has a strong pulse, normal skin color, and normal sensation below the level of the injury. If you cannot feel a pulse in their foot after a severe leg fracture, the broken bone is likely pinching the main artery, starving the limb of oxygen. This is a massive medical emergency that requires a doctor to immediately pull the bone back into place to restore the blood flow. The most dangerous orthopedic complication you must memorize is compartment syndrome, which happens when massive swelling builds up directly inside the enclosed muscle tissue. Because the tough skin around the muscle cannot stretch, the extreme swelling physically crushes the nerves and blood vessels, causing agonizing pain that is entirely out of proportion to the actual injury. Even powerful pain medications like morphine will not help a patient suffering from compartment syndrome. The only effective treatment is a surgical procedure called a fasciotomy, where the doctor slices the skin and muscle open to instantly release the extreme pressure. You must also treat major pelvic fractures and femur fractures as immediate life-threatening emergencies due to the massive risk of internal bleeding. The pelvis and the heavy thigh bones hold massive blood vessels, and a severe break can easily cause a patient to bleed to death entirely inside their own body. For a broken femur, we apply a specialized traction splint that tightly pulls the leg straight to reduce the bleeding and muscle spasms. For a cracked pelvis, we rapidly wrap a tight pelvic binder around their hips to forcefully squeeze the broken bones together and physically stop the internal bleeding. Dealing with traumatic amputations requires specific, careful steps to preserve the severed body part for possible surgical reattachment. You should never place a severed finger or limb directly onto solid ice, because freezing the delicate tissue will completely destroy the cells and ruin any chance of saving it. Instead, you must gently rinse the part with sterile saline, wrap it in moist sterile gauze, and place it inside a sealed, watertight plastic bag. You then place that sealed bag into a larger container filled with a mixture of ice and water to keep it perfectly cool but not frozen. Transitioning to environmental emergencies, we must discuss the critical differences between mild heat exhaustion and deadly heat stroke. A patient with heat exhaustion is heavily sweating, dizzy, and severely dehydrated, but their brain is still functioning normally. Heat stroke happens when the internal cooling system of the body completely breaks down, causing the patient to stop sweating entirely while their internal temperature skyrockets to dangerous levels. The biggest warning sign of heat stroke is a sudden change in mental status, like severe confusion or a coma, requiring you to rapidly cool their body with ice packs and cold intravenous fluids. On the opposite end of the thermometer is severe hypothermia, which occurs when the core body temperature drops dangerously low due to cold weather exposure. The most important rule for treating a severely hypothermic patient is to handle their body with extreme gentleness at all times. When the human heart becomes severely cold, it becomes incredibly irritable, and simply bumping the patient roughly against a bed can instantly trigger a lethal heart arrhythmia called ventricular fibrillation. You must carefully and slowly warm their core using heated oxygen, warm intravenous fluids, and specialized warming blankets. Frostbite is a localized cold injury where the actual skin and underlying tissues literally freeze solid, commonly affecting the fingers, toes, and nose. You must never aggressively rub or massage frostbitten skin to warm it up, because the sharp ice crystals frozen inside the tissue will act like tiny knives and destroy the delicate cells. The correct emergency treatment is rapid, gentle rewarming by plunging the frozen limb directly into a bath of warm, circulating water. This rewarming process is incredibly painful as the blood flow returns, so providing heavy intravenous pain medication is an absolute requirement. Toxic snake bites are another complex environmental emergency, usually caused by pit vipers like rattlesnakes or copperheads. If a patient is bitten on the arm or leg, you must keep the injured limb perfectly still and positioned exactly at the level of their heart to slow down the venom. You must never apply a tight tourniquet, and you should absolutely never try to cut the wound or suck the venom out of the skin. Your primary medical intervention is closely marking the swelling with a pen every 15 minutes and preparing to administer highly specialized anti-venom medications. Submersion injuries, commonly known as drowning, create severe respiratory emergencies because the lungs become filled with water or severe inflammation. Even if a patient is safely pulled from the water and seems perfectly fine, they can develop secondary drowning hours later due to the delayed inflammatory response inside their lungs. Additionally, if the patient was injured diving into shallow water, you must immediately assume they have a broken neck. Applying a rigid cervical collar to protect their spinal cord is your absolute first priority before managing their airway or breathing. When assessing patients with severe burns, you must quickly calculate the total body surface area affected using a standardized method called the rule of nines. This simple system divides the adult body into distinct sections representing 9% each, such as the entire head being 9% and each entire arm being 9%. The entire front of the torso is 18%, the entire back is 18%, and each entire leg is 18%. Memorizing these specific percentages is absolutely essential, as you will definitely have to calculate the total burn size on your certification exam. Once you know the total burn percentage, you use it to calculate the massive amount of intravenous fluids the patient needs using the Parkland formula. Severe burns cause the blood vessels to leak massively, meaning the patient will quickly die of hypovolemic shock if you do not replace their lost fluids immediately. The formula tells you exactly how many liters of fluid to give over the first 24 hours, and the exam expects you to know that exactly half of that massive fluid volume must be given during the first 8 hours alone. If a patient is pulled from a burning building, you must always suspect severe carbon monoxide poisoning from inhaling toxic smoke. Carbon monoxide is an invisible, odorless gas that aggressively attaches to the red blood cells, entirely blocking oxygen from entering the body. The tricky part is that a standard pulse oximeter clipped to their finger will show a perfectly normal oxygen reading, even while the patient is internally suffocating. You must ignore the normal monitor reading and immediately apply a specialized mask delivering pure, 100% oxygen to force the carbon monoxide out of their blood. Shifting our focus to psychosocial emergencies, treating severe mental health crises requires intense empathy and clear, direct communication. When assessing a patient for suicidal ideation, you must never be afraid to ask them directly if they are having thoughts of ending their life. If they say yes, you must then ask if they have a specific plan, because having a detailed plan makes them a massive, immediate risk to themselves. Your nursing priority is to place them in a safe room, remove all dangerous objects, and assign a staff member to watch them continuously on a one-to-one basis. You will also encounter severely agitated or aggressive patients, requiring you to master the delicate art of verbal de-escalation. Always keep a safe physical distance, ensure you have a clear path to the door, and speak to the patient in a calm, non-judgmental, and quiet voice. You should never argue with their delusions or try to aggressively force them to calm down, as this will only escalate their violent behavior. If verbal techniques completely fail and the patient becomes a physical danger, you will quickly administer chemical restraints, like haloperidol or lorazepam, to safely calm their brain. Physical restraints, such as tying the wrists of the patient to the hospital bed, are strictly an absolute last resort when all other calming methods have failed. The legal rules surrounding physical restraints are incredibly strict, requiring a specific doctor order and continuous, heavily documented monitoring by the nursing staff. When a patient is restrained, you are legally required to personally check the circulation, skin color, and pulse of their tied wrists every 15 minutes to ensure you are not causing nerve damage. Finally, we must discuss disaster management and mass casualty incidents, which completely change the normal rules of emergency nursing. In a normal emergency room shift, you devote massive resources to save one dying patient, but during a mass casualty, your goal shifts to doing the greatest amount of good for the greatest number of people. We use a rapid triage system to quickly sort patients into 4 color-coded categories based on their breathing, circulation, and mental status. This fast sorting process ensures that the limited doctors and supplies are given to the patients who actually have a chance to survive. The most difficult ethical concept in mass casualty triage is the black tag, which is assigned to a patient who is expected to die or is already deceased. If you open the airway of a victim and they are still not breathing on their own, you must instantly assign them a black tag and move on to the next person. As a nurse trained to save every life, walking away from a dying patient is emotionally agonizing, but it is absolutely necessary during a massive disaster. Spending 10 minutes performing CPR on a black tag patient means 3 other survivable patients will die while waiting for your help. On the other hand, the red tag is assigned to patients with immediate, life-threatening injuries who can actually be saved with rapid intervention. A patient gets a red tag if they are breathing dangerously fast, if they have no radial pulse at their wrist, or if they are unable to follow simple commands due to a head injury. Understanding these clear triage categories and prioritizing resources without letting your emotions dictate your medical decisions is the ultimate test of an expert emergency nurse and a massive focus of your final exam. I want to sincerely congratulate you for completing this final section and finishing the entire exam preparation course. You have mastered an incredible amount of complex medical knowledge, from triage foundations to life-saving trauma interventions. I highly encourage you to complete the attached practice test for this final section to solidify everything you just learned today. Practice questions deeply improve your retention and are the ultimate key to passing your certification exam, and this final test is included right here with this lesson. Embrace this active learning, trust in the hard work you have put in, and naturally transition into your final exam review with absolute confidence in your success.